Thank you for joining us today. Even though a great deal of data are available, researchers studying healthcare safety, quality, and cost and access are confronted by significant obstacles to getting the data they need. I'll share with you a humorous illustration of that point called Finagle's Law of Data. That law says the information you have is not the information you want. The information you want is not the information you need. And the information you need is not the information you can obtain. Let me give you an everyday example of just that kind of problem with getting the data that we need. It happened to me not very long ago. I went into an upscale fast food restaurant, wanted to have breakfast, asked if I could have 2 egg whites scrambled, and was told no, that wouldn't work, wasn't on their menu. So I ordered 2 scrambled eggs. At the point of sale, the person taking my order had a wonderful automated, computerized cash register system that allowed her to key in the order that was instantly transmitted to the kitchen, and data were captured within that computerized system that would be useful for them in terms of gathering information on food costs, portion control, time from point of sale to the food arriving at the table, profiles of the purchaser and the purchase they made. It was a fascinating piece of equipment, and what's on the screen now is information that came from the website of the manufacturers of that technology called the Quarian POS or point of sale system. So the person keyed in 2 scrambled eggs, which were on her keyboard. The order went directly to the kitchen, and in a matter of just a few minutes, 2 enormous platters of eggs arrived at my table. And I asked their server if he was sure this was my order. It certainly didn't look like what I was expecting. And he said, oh yeah, it was. It was 2 orders of scrambled eggs. And I said, well, give me an idea of how those were fixed. How many eggs are here? He said, well, each order was made up of 2 ladles of eggs. And I said, well, how many eggs do you estimate were in a ladle? Well, there were 2 eggs per ladle. So in all, I had received an order of 8 scrambled eggs. I'd gone in asking for egg whites. What I received were 8 scrambled eggs. I hope that story illustrates some of the concerns that I have about applying principles from sales and manufacturing to processes of quality in healthcare. When we rely on easily captured data for what we consider to be knowledge of what is actually going on, we're setting ourselves up for some error. Now, Sean Clark had already warned us about this in some ways in a paper or in a chapter that he wrote called The Challenges and Risks of Grasping at Shadows in the book Complexities of Care or Nursing Reconsidered. Sean Clark warns us that we are sometimes grasping only at the shadows of nursing when we collect data for different purposes in healthcare and then expect that it give us information about what actually goes on. If there are these flaws that are built into the systems that are already in place to collect quality and safety data, like our Quarian point of sales cash register, then we run a serious risk of using these data to make decisions. But that leaves us in a dilemma because shouldn't we be accountable? And if so, how? I want to briefly do a sidetrack here and talk about accountability. It's such an interesting term, and when one looks it up in the dictionary, we see that it was first used in the English language at the end of the 18th century, just about the time that the Industrial Revolution was actually flourishing. And the definition in the dictionary for accountability is the quality or state of being accountable, especially an obligation or willingness to accept responsibility or to account for one's actions. In a paper titled Accounting and Objectivity, the Invention of Calculating Selves in Calculable Spaces, Peter Miller quotes Nietzsche, who said that with the aid of the morality of mores and the social straitjacket, man has actually been made calculable. And it's a use of the term that I really want us to consider as we go forward with the rest of this discussion. Becoming calculable. What does that mean? I had become calculable in the restaurant when I asked for eggs, but I could see quite easily how mistaken that calculation was. But Nietzsche goes on to say that before responsibility can be assumed or imposed, there's a preparatory task that must take place. One must first make men, or nurses in this case, to a certain degree necessary, both uniform and like among like, regular and consequently calculable. In other words, for us to be accountable, we have to be calculable, and for us to be calculable, we have to be alike. Otherwise, the data we're collecting can sometimes lead us astray. What happens when we start to think about accountability in healthcare also, I think, leads us into the understanding that these calculations and accountability get translated into prescribed financial targets and objectives. Very much like the data on the food service getting translated into information that could be used by the restaurant owner. I want to illustrate the point here now, being specific to healthcare, with a couple of examples about data collection that's already going on and some of the problems that might be accompany that data collection. What you see on the screen here is a screenshot from the Texas Department of State Health Services, where our state data or healthcare information is collated for use by both consumers and by researchers. And one can go at any time to this website and download a great deal of data about healthcare and healthcare outcomes and cost in our state. And consumers do use this, and also researchers use it. I want to draw your attention to the little box that mentions below the Consumer's Guide to Healthcare and what the purpose of these data collections are and the law that makes them mandatory. So these data are being collected. There's a tremendous amount of data available to consumers and to researchers to use to make decisions. Here's an example of what a consumer might see in what they call a fact sheet on influenza in our state. And it gives a capsule version of data about the number of discharges with the diagnosis of influenza, how long the average stay in the hospital was, what the average cost was, and so on and so forth. Information that should be useful for comparing what you paid or what you think you might pay for a service and what the average of the state was. Now that all seems quite straightforward, and those data might seem simple enough to collect until you think about that simple scrambled egg example. And sure enough, what accompanies on the website those simple fact sheets are approximately 80 to 90 pages for each quarter of data reporting. Those 80 or 90 pages of disclaimer on why those data cannot be used easily for comparison. Take a look at the circled information at the top of this excerpt from those disclaimers. It gives some examples for why hospitals who are reporting these data are saying they might not be useful. For example, the one on top says that they are mandated to use the ICD-9 code, and this is mandated by the federal government. The hospital complies with those guidelines. However, this is often driven by physician subjective criteria for defining a diagnosis. For example, one physician may diagnose anemia when a patient's blood hemoglobin falls below 9.5, and another not diagnose that condition until below 9.0. So in other words, yes, we have some data on, for example, anemia, but we need to be careful because we're being told that that definition in the ICD-9 code is dependent upon individual judgment from physicians, and so this can be misleading. Next, in the middle of the page, the codes, we're warned, do not distinguish between conditions present at the time of admission and those occurring during hospitalization. So if you're interested in infection rates, you must be cautious because, according to this disclaimer, it's not always possible to determine if the patient had that infection before they arrived, making it difficult to obtain accurate information about such things as complication rates in these hospitals. Going on, the final example I'm going to give you from these 88 pages of disclaimers is this one. Data are limited in the number of data fields that a hospital is permitted to populate. So in other words, the state's data file may not fully represent all the diagnoses treated at the hospital or all the procedures performed. And we're warned that this can alter the true picture of a patient's hospitalization, sometimes significantly. The point I'm making here is, while we have tremendous amounts of data available on these websites and researchers have access to them, we also have a tremendous burden of disclaimer that we have to ferret through to see how trustworthy these data are. So I think I would ask you, how can numbers tell the whole story? That very simple fact sheet looked quite straightforward, but there must be more to the story, and we're warned by those disclaimers that there indeed is more to the story. Let me give you one more example of some data that is being collected, very much like restaurants collect their food service data. Hospitals, almost universally, in my experience, are monitoring productivity in terms of labor cost for care provided. And what you see on this screen is a screenshot from a vendor who has a product that can be used as a dashboard by nurses and administrators to monitor productivity of a particular unit. And by productivity, here's what they mean. 100% productivity is providing care with the fewest possible staff at a particular level of patient census. In other words, units have a matrix that tell them if they have X number of patients, then they can have X number of nurses, X number of aides and secretaries, and so forth. So productivity is monitored in this unit that you see on the screen, and on average being 94%. And you can see, if you read this fine print under the title, Productivity Index, that the department that this is representing is what they call on the watch list. In other words, they're not meeting their productivity target consistently. Now that target is the solid black line in the horizontal blue table that you see, or control chart. And the blue up and down line is their performance over time. So when that performance drops below the dotted line at the bottom, or should it ever reach or exceed the dash line at the top, there are problems identified through this software package and transmitted, just like my order was transmitted to the kitchen. This kind of productivity data and being out of bounds in productivity is instantly reported to administration and to managers of the unit. So nurses who are balancing things like staffing and productivity know that they must stay within those bounds and have workarounds that allow them to do so. If you notice the dates that are along the bottom of the x-axis, you'll see that those are in increments of 2 weeks. And in our recent study funded by Inquiry, where we looked at staffing on weekends and found that often they were quite low and in nurses' opinion, inadequate in some cases, we found that nurses had learned how to do workarounds with productivity so that if they exceeded their or had too many staff, meaning their productivity went down, if they had that in 1 day or 2 days in a week, they knew that by the end of the pay period or the end of the period for which they were being monitored, they had to make that up by cutting back severely. In other words, they had learned to balance staffing so that they could keep their productivity in the good zone, as is indicated on this slide. So my disclaimer about these data would be that while you might look at a unit that on average looked quite good, and this one does not, but if one did, you might conclude that that was always the case, when in reality there were times during the period where staffing was quite low in order to maintain that productivity level. So what's the researcher to do if we have these pitfalls and obstacles in getting the data we actually need that are being collected? How are we going to judge the veracity of the data, the validity of the data, the helpfulness of those data? And I would suggest to you that one means might be through institutional ethnography. Institutional ethnography focuses on how an institution works up information. In other words, if we were to do an institutional ethnography on that restaurant, we'd be very interested in how they worked up my order for 2 scrambled eggs into something that turned out to be 8 scrambled eggs. We'd follow through and find out how that could have happened. We'd be interested to know how rules created somewhere else outside the workplace in order to control the work actually operate. As in my example with the productivity chart, the rules that were created that defined productivity were created somewhere not at the bedside, and they were created in order to control work. But how they might actually operate would be found out through institutional ethnography and interviewing the people on the spot who worked every day with those rules. Institutional ethnography would help us focus on whose standpoint is valued in creating the knowledge about the institution and its output. For example, again with my eggs, my standpoint was not as valuable in that system as the standpoint of the kitchen or the person taking the money or the person deciding how many eggs to order. The standpoint valued is critical to knowing how that information gets created and how it can be valued. We're especially interested in the unintended consequences of institutional rules. Again, very much like my egg example, but again in the example of productivity charts, the unintended consequences of the institutional rules best described in that example of the productivity chart, where nurses had learned that rather than maintaining constant productivity, they often had to staff up or bring in extra staff when patients' needs required it. But they had the unintended consequences of cutting back severely at another time in order to stay within bounds of their monitoring. That was never the intended consequence, I'm sure, of the people who started to monitor productivity, but it's the workaround that nurses had discovered. And institutional ethnography is very interested in how individuals do or do not work around institutional rules. We're interested in how that information is gathered by an institution to create the rules and consequences of the work of individuals. So that's what institutional ethnography really does. Sort of the underlying philosophy of institutional ethnography is that any healthcare setting is going to operate on the basis of the knowledge it collects, and that is the product of careful analytical and technical workup. All institutions need information, and they all work it up in a way that is valued by the standpoint that is in control of that workup. And they create such things as performance data, financial reports, satisfaction scores, benchmarking, so forth. Then that information that's worked up is used to coordinate people and resources and activities, making them manageable and accountable across time and space. So am I suggesting that our ethnographic approach should take the place of all those data that are being collected? No, I'm not. But I'm saying instead of supplanting those efforts, it could augment or extend them. I think that approach of the blended methods, both using the quantitative data available but making sure through ethnographic approaches that those data represent what we think they do, would help us to reduce the impact of Finagle's law on our research and decision making. Thank you.